So the next session is a workshop, following on from the work we've done in April. Bizarrely enough, at the time we didn't know that was the beginning of the sit-in on the 6th of April when we had our alternative health policy meeting, and we managed to get the endorsement of the health policy, alternative health policy for the transition year, for the first year of the transition, which is being submitted to accompanying, the health secretary, and hopefully is the policy that's underpinning the work done over the next year. It's a workshop where we're going to look at specific aspects of healthcare. Sarah was recently in Sudan, in Khartoum, met with the Secretary of Health, accompanying, met with the Department of International Development, UK Department of International Development, based in Khartoum, and met with the Secretary for Social Welfare as well, and the British Ambassador, I found there as well, and they identified a few key health priorities for Sudan, and they're in a way looking for some support and a report about which are the priorities for this first 3 years. Accompanying has worked hard with Sarah about trying to get support from colleagues here back in Khartoum, from diaspora, about just some brainstorming and trying to think about what should we focus on. After Sarah gives a brief, I'll just identify a few key points, because I'd like people to separate into 6 groups, each group to work on one item. So see which group you feel that you've got something to contribute, and please do just move around. Yeah?
So as Sarah said, that we were trying to think about what's next. So as you know, what are we going to do, and how can we be more practical? And the first was about approaching DFID. We have been in touch with DFID, which is the Department of International Development, since the beginning of this term, so it's not something new. So we met them in January 2018, and we were talking about what sort of projects they were doing and how can we help. But at that time it was a bit difficult, and I think they were feeling like they cannot work without approval from the Minister of Health in Sudan. Now, then we had a second sort of discussion after the revolution, and they have identified certain areas that they feel we may be able to contribute to. Following that, we had a panel of expertise from the SDU-UK who helped with writing sort of brief sort of outlines for these areas. Today, I think this is an important opportunity for the whole group to contribute, and then we summarize and we add that to provide the information to DFID and to the Ministry of Health. So the areas that they have identified, number one, they are very concerned about governance, and they're talking about governance in relation to the Ministry of Health. The second is about how are we going to get a trained health cadre that will stay sustainable, not only in Khartoum and Madaniya, but in all different areas. How can we contribute to the areas of conflict and rebuild the health services? They have identified safeguarding as an area where there is a defect and there is no policies, very clear policies in the Ministry of Health. And then there was the level or they looked at it as a pyramid, so the governance at the top, and the base of the pyramid is the specialities, but mainly primary health care and emergency care. They are interested in reproductive health because of the high maternal mortality rate, and as well neonatology because of the high level of the neonatal as well mortality rate. So this is the sort of the pyramid that we felt that can be the structure to think about how can we help. We discussed these points with Akram, and he has got some areas that he is already working on in relation to governance and primary health care and emergency care, but there are certain areas that I think he would appreciate the contribution. And I think as being clinicians, senior clinicians, trainees in the NHS and NHS England, we may undervalue our expertise, but I think we can provide a lot of information in these areas. I hope that's...
So as Sarah said, 6 key items: governance, workforce, safeguarding, primary care, conflict zone, and the priority specialities, namely mental health, I'll say that first, reproductive health, and, yes, sure, and the emergency care. So if people can divvy up into groups, and I'll just put some reminders about the key things that you need to be looking at. So in governance, maybe to think about structure of governance, safety, effectiveness, quality, equity, training, and evidence-based aspects. So whichever table decides to work on governance, these are key themes maybe to consider. Working on workforce, it's always important to remind ourselves 70% of the population in Sudan reside in rural areas, while 70% of health workers are in urban areas, the majority being in Khartoum, as we know. Think about migration, think about migration of workforce, think about training, supervision, reporting, how that would work. Safeguarding, thinking about statutory requirements and legislation, what safeguarding would look like as a framework, issues about training, how will we implement a safeguarding process, and then thinking also about which are the vulnerable cohorts. So I'm talking about children, older people, patients are vulnerable cohorts. Conflict zones, and here again maybe a focus on security, deprivation, the food scarcity in the conflict zones, displacement. Gender is a major issue in conflict zones, as is trauma. Just a point about primary health care. Primary care, a healthy population, is a productive and earning population that contributes to the economy. So primary care really has to underpin whatever work we think about in Sudan. The role of primary care in improving population health is well established and evidence-based. And the key functions we're looking towards are prevention, chronic disease management, as well as managing minor ailments and injuries. Priority specialties, like I said, reproductive health. Sarah elaborated on the high rate maternal mortality rates. Emergency care specifically, and we're talking about outside Khartoum. All of this, I think it's really important for everyone to have that in mind. We're not talking about Khartoum, we're talking about the whole of the country. And mental health. People may not know this, there's no mental health outside Khartoum. Mental health care, that is. Join a group. We've put in some of the flip chart sheets across the table, so just see which one attracts you, and you can sit down and join whichever one. More sheets there, and yeah, contribute to your thinking, and we welcome your contribution. I'll give you about half an hour, maybe, and then we'll try and regroup again, and each group to just provide a short debrief.
I see. يعني private specialties كويس. طيب من الحاجات اللي الناس ذكرت مثلا
Who's ready? شكلكم انتوا ready. Yeah, okay. التوبيك شنو انتوا يعني؟ صح؟
More than one year sports
Excuse
person.
me, everyone. Can we listen?
Listen, everybody, please. Thank you.
Order. Order. The priority specialities will be presenting their thoughts. If we can all listen, please. Thank you.
May I start with the most important thing that underpins actually the practice of medicine, and no medical specialty will go anywhere without us. And unfortunately, it has been completely missed. I'm talking about laboratory services. Actually, laboratory service needs a whole shake-up, and it needs to be recognized. There is no department of laboratories or laboratory organization in the Ministry of Health. So I would really recommend that there be a section in the ministry, especially for the laboratory, إدارة المختبرات. The laboratories needs to be regulated, the training, the equipment, the quality control, and the licensing of labs. This is just about a few of many things that the laboratory encompasses. And since we are talking about laboratories, actually I'm a histopathologist and I cannot really ignore the importance of oncology services and screening programs. And considering the Sudan, we do not have any proper running screening programs with the commonest cancers that also are really prevalent in Sudan and we don't know anything about. I'm talking about cervical screening, breast screening, bowel screening as well. And in addition to the lung cancer, which nobody actually knows the magnitude of, and we have an emerging problem of asbestos exposure, especially in the new villages of Halfa Jarida and even in Khartoum. I came to know that there are a lot of asbestos buildings, schools, and these are just pulled down without any precautions. So we really have got an emerging, if not already established, health problem. So screening programs and cervical screening actually now is just depends on a test for HPV, the cervical smear and more. It doesn't require the screening of slides and specialized technicians. And I think that's about it, just in a nutshell. May I just give the chance to the trauma?
I'm going to talk about the requirement of emergency care and mainly trauma services in Sudan. I think we've all seen how the trauma services were actually not efficient at all during the last 10 months since the start of our latest revolution. The main thing about trauma is basically we need centralization of trauma care. As you can see here in UK there is around 25 major trauma centers, whereas in Sudan there is no one specialized major trauma center where you can actually manage the trauma care in the first hour and make sure that patients don't die within the first golden hour. Statistically, in 2016, there were like more than 7,000 road traffic accidents, and around 2,000 of them, actually, of these patients died on scene. And you can see that there is also a lack of the ambulance care and ambulance teams, whereas in developed countries, nowadays there is access to even air ambulance where you can get patients transported even from the rural areas to the major trauma center and make sure that they receive their essential care and survive. An essential part of the trauma care is actually the rehabilitation following survival from these traumatic injuries. And my main specialty, which is spinal injuries rehabilitation, there is no existence at all in Sudan. Unfortunately, over the past 10 months, we've had to transfer patients abroad to manage lots of patients from the revolution. And my hope is that in the future, these services are made available in Sudan. I'm going to pass the mic to my colleague.
Of themes about mental health.
Excuse me, I'm being generous for this still because they are priority specialities. So it's a lot of specialities. don't expect that you're having that much time.
I'm going to be quick. So in terms of mental health priorities for Sudan, we've talked about stigma and tackling the stigma associated with mental health and mental health issues, not only among the Sudanese people, but also among the health professionals, understanding the role of psychiatry in improving population's health. We've also talked about understanding the causes of mental health problems in Sudan, their prevalence, and the culture underpinning of mental health problems. And the last thing we've talked about briefly was the culture element in psychiatry and the involvement of religious leaders and traditional healing in tackling health problems, specifically psychotic problems.
Thank you very much. Any other points? Thank you. Can I have the sheet so I can? Okay, thank you very much. Second table. That's fine. So we'll take it as well. Do you want feedback? Conflict zone table.
Right. We have spoken about few things actually. Number one is redefining the way conflict zones. I thought my voice is so good. Anyway, we've spoken about how to redefine the word or the term conflict zones, and we've spoken about also part of delivering medical services to the conflict zones should be together hand in hand with peace building, and that will in turn will sustain the flow of medical services to the conflict zone. By nature, they are actually in the peripheries away from the center, and that will make some few changes in our way of thinking about زي مناطق الشبه الزمالك وهسه مناطق بتاعت حي الموت. And also, we've spoken about the change of the demographical change of the population, especially after the mass migration from conflict zones to the centers and stuff. So basically, the people who are living in some areas, they are no longer belongs to those areas. They are there because of the conflict. So the way health service should be delivered to them should be changed. It's not an emergency way of doing it, but to sustain it. And the way we agreed actually how to sustain that is to mobilize some of the centers from Khartoum and central areas to be in areas where there is medical schools and there's a training center, so doctors can travel there, they can deliver health services to these areas as well as to continue their training as part of the solution. And one of my colleagues here, there's a very valid point regarding implementation of the GP service as a primary health care first line to Sudan, and that will automatically help in sustaining also the flow of medical services from the center to the peripheries and the conflict zones. And there's few mechanisms by which we can do that. We made it like bullet points. Number one, training people in the conflict zones and in the peripheries how to deliver primary health service like nursing schools, like midwifery and health service delivered by the health visitors. And what else?
Emphasizing security.
Right, yes, and we cannot speak much about security without mentioning the wars and the things that is happening. So basically, deliver health services to the peripheries and to the conflict zones should be hand in hand with maintaining the ideas of peace and how to make these ideas sustained and to be delivered well to the peripheries of Sudan. And that will there itself will reorganize the people and staying back home because they just wanted good service and good life and حرية وسلام وعدالة.
Thank you very much. I'll give people an opportunity to ask questions or add a comment towards the end, but I'm just aware of the time factor, so I'll get everyone to debrief before we give opportunities. This is stable primary care.
Salam everyone. Our topic is primary primary care, which, as we all know, is fundamental really for healthcare in the country. So we sort of, you can divide all our points into basic categories of increasing accessibility and also preventative medicine. So one of our points was to sort of re-establish primary health in general in Sudan. I think over the last 30 years it's really sort of fallen apart. So our aim is to start kind of from the grassroots level, training locals in each village, in each neighbourhood, to be midwives, to be health visitors, to be paramedics, to kind of reduce that need for a trained doctor, because there just aren't enough, unfortunately, in Sudan. So if we can ensure that there's one of each of those kinds of people, then they can at least provide the kind of basic health care, and also be linked with doctors and hospitals in the sort of major cities. As sort of part of that, we thought we could use the medical schools to help the students, to help train those people to go out into those sort of villages and neighbouring areas. Medical schools themselves can also run projects sort of similar to what we saw in the video before, running sort of mobile clinics, if you like, where they can do the kind of initial basic assessment and obviously under the supervision of doctors or trained people can deliver the healthcare. They can also, I think we thought that using technology would be helpful as well. I think it's important not to underestimate the sort of power of social media, which I think particularly the medical schools will be able to use. And we thought that using projects, linking with the World Health Organization, with UNICEF, to prioritize things like immunizations, access to clean water, things like that would be very helpful.
Thank you, Sam. Well done. So basically, our idea is that we would like to present a project which is practical, and the government can take straight away and perform without the need to big funds or big resources. So we discussed at length how can we actually use what we have in all the towns and villages of Sudan, far from the big cities, to be able to build from the ground up. So that's why we talked about training personnel who don't have to have medical degree to actually be able to be available and very near, because we know in Sudan accessibility is a big issue. So for somebody, for example, to deliver, because they have difficult delivery, they have to travel for 2 hours. But if you have a trained midwife with you in the village, then you don't have to do that. That's why our idea of one midwife, one paramedic, one health visitor for every village has come from. Secondly, just the bits that Razan didn't cover, we also know we need to tackle the big health problems in Sudan, illnesses like malaria and TB. And we both know these illnesses are very easy to eradicate, not just treat. And that's why we need to talk about public health awareness and use things like TVs and media. But on top of that, we would like to restart the health education in schools, as some of us might remember that used to be available in Sudan. So we'll be able to recognize illnesses like childhood illnesses from early age. We will also take the chance to educate students and let them know, pupils, how to prevent illnesses by simple things like washing hands and the like. So this has to come from the grassroots of the population, and then we can talk about how to prevent illnesses like malaria and TB. Also, the last point is the chronic illnesses. Again, this is a primary health issues. We all know about things like hypertension, diabetes, and the role of lifestyle in these issues. And again, we go back to education and so on. So our main point is we are not going to concentrate on Khartoum, we're not going to concentrate on big cities only, but we're going to talk about Sudan as a very wealthy and very resourceful country, and that's where we're going to start from. Thank you.
Just one point we mentioned, myself, Ahmed and Hassan, because we have been there before, that we did have a very good primary care system in the Sudan. What we need is to revive it. Some of the infrastructure is still there, the health centers and the rest of it. What we need to rehabilitate these health centers. Madrasa al-Musa'adin al-Tabi'in medical assistant schools was there, I don't know if it's still there or not. Probably some of the teachers and trainers are still available now. And the midwifery schools, it was in Lubayid, Shandi, everywhere. What we need is to go back to pre-Al-Imla system. If you can do that, that will be a big achievement. We talked about the days where we have Sahha Madrasiyah, health, when we were young. We will have visits from doctors, and they will do urine analysis, they will do eye tests, they will do dental examination, they will do, all we need is to go back there.
Thank you very much. Can I ask that just whatever you described, if we can just hang to it there, because we'll take it to reform back the report. Thank you. And this table is safeguarding.
So we're going to talk about safeguarding. Me and the group, we thought that half an hour is not enough to discuss this issue. I think this is a big topic, which is, I think hasn't been raised, or there is no awareness about it in Sudan yet. So I'm going to try to be brief in talking, and if one of my colleagues, if I miss anything, you can add later. So we defined first what's safeguarding. So safeguarding is the well-being of a human, and it covers the health and the need of the human specially deprived. There are 6 principles of safeguarding, which is empowerment, which is to support the people to raise their voice and get supported. Prevention, proportionately, protection, accountability, and partnership. So these are the 6 principles of safeguarding. We also talk about vulnerable groups. I'm not going to go on details, but we included conflict area is a very important area because people on these areas are vulnerable. We talk about the main thing is we don't have a policy. So the main issue is to have a policy, and the other thing is that we don't think there is a legislation or a law in Sudan. We can take from the international examples. We talk about advocate for safeguarding, and the most important is training. The training is not just for the health service provider. Training includes the whole community, education, and for example, social service, and the whole community. There is one important point in training is about there is a high rate of literacy in areas in Sudan. So we think people in these areas, they're not aware about their rights. And we think some in these areas, people, they don't think safeguarding is their priority because they are not aware of or they don't know. How to implement this? To implement the safeguarding policy, we need a lead to implement it. Who's responsible for safeguarding? We think everybody is responsible. So community, health service, social service, education. So everybody is responsible. And I will pass the mic for any of my colleagues if you want to add anything that I missed.
Okay, so I think my colleague has done a great job. We covered all the areas that we have discussed today. I would like just to re-emphasize the point of legislation. I think one of the biggest problems we have in several countries, and particularly resource limited, is the ability to bring the idea that's already been implemented in many parts of the world, and we all know what it is exactly, but how do we actually put it in place and be able to make sure it is followed through? and the ability to set some sort of a policy that's been agreed on, that not only the Ministry of Health and those who are in the medical field, but actually the other ministries that's equally responsible for this, including even the police, the army, and everybody that's have some input into that. And at that point, we'll be able to move this into legislations and to be able to become part of the Constitution itself. And that will make most of these areas a lot more easy to implement, and it will be, protected by law. So it will be very difficult for anybody in the future, regardless of the government, regardless of anybody, that people know their rights, and they will be able to defend it themselves. And I think safeguarding is the essence of people have the ability to be able to speak for themselves and take it to the next level.
Thank you very much. That's excellent. Thank you very much. And now we come to governance.
Hello everyone. In the governance team here, we try to provide the structure for the governance of Sudan or the new Sudan. So we put a mind map and draw the structure, and put also the regulations to ensure the execution of this structure and the development of this structure. Firstly, if you can see it all, we will have a directories, just like Wazarat. These directories should provide legislations. Already there is legislation, they have to activate these legislations as said by the Dr. Sia. نحن في السودان عندنا legislations بس دايرين to activate the legislations then. add any legislations, يعني if we need any حاجة جديدة we will add committees دي. The legislations they should be divided into three: the system governance, the financial governance, and the clinical governance. The system governance will talk about the hierarchy of the governance in Sudan, or the health system. It should be a federal system or should not be a federal system? We had a lot of debate here, but معظم الناس قالت إنه المفروض إنه يكون centralized to لحد ما نصل شوية equity between الولايات، لأن الولايات في great difference or huge difference between الولايات دي. حتى لما نكون النظام centralized بتكون عندنا قبضة عليه شوية. We can prevent people مثلا زي الدعم السريع اللي يتدخل في واحدة من الولايات ولا حاجة دي. At least الكنترول شوية بيكون أقوى يعني. كنا again نرجع تاني عندنا financial governance. Financial governance should provide the regulations of the financial expenditure. They provide the fund للحياة دي. Also لازم نخطوا على الرول، يعني حنصرف في شنو، حنصرف كم، حنصرف ليه. لازم to answer these important questions. Also the clinical governance, they should provide guidelines for practical use. Or should be evidence-based. يعني لازم الحاجة تكون evidence-based guidelines for the Sudan. To ensure the legislations دي لازم يكون عندنا حاجة اسمها supervisory bodies. The supervisory bodies they should supervise إنه legislations to be executed. Also we will provide حاجة تانية عشان supervision يكون من كل الناس إنه لازم to provide transparency. When you provide transparency أي زول بيقدر يشارك في العملية بتاعت الأسسمنت أو بتاعت البناء. In addition لذات يعني نحن هسه عندنا structure ده هو executed. نحن لازم to develop the structure ده. To develop such a structure should be continuous monitoring and evaluation. لازم يكون في feedback للإيفالويشن بتاعنا كده نشوف الحياة الغلط وين والحياة نصلحها تاني كيف ينفع. I'm done. هخلي لو في التيم بتاعي يقدر يتكلم.
ما شاء الله عليك، تحس ثورة الشباب نجحت لي.
Excellent. Thank you very much. And now we move on to workforce. Okay, so that underpins it all.
So we spent a lot of time actually talking about what is not working, and we've identified very quickly that the system is broken. So we looked at four main categories, the first one being training, and we've realized that the training process is disastrous. So we need to implement a sophisticated training process. That includes, as a start, providing training subsidies, for example, or sponsorships, because what we've realized is
doctors are spending a lot of time and money trying to fund their own training. So the government actually doesn't provide them any funding opportunities. They don't get any salaries to subsidize their lifestyle. So whereas they have to fend for their own selves and try to make more money out of working in private hospitals, they're almost working 24 hours, so that reduces their quality of life. It reduces the quality of their work. There is obviously, as a result, high retention or poor retention rates, because doctors are seeking opportunities elsewhere where they can subsidize their life. They've got kids, they've got families, they've got lives to live. So we need to look into the whole process of training, provide a structure for training, distribute workforce appropriately. So again, the idea that everything is centralized to the main city, with the capital city, rural areas are missing out on good quality doctors. So we look at how we distribute the workforce appropriately. And then we're looking here at medical student training, facilities for medical schools, ratio of student to trainer, so literally a complete overhaul of the training process and procedures and facilities. One of the, obviously, the main items we've identified is very poor work-life balance, very poor remuneration, salaries, benefits, almost non-existent, and that's why people leave the country. The next point, obviously, retention and migration. So how do we improve that? We look at improving facilities. Doctors are working in hospitals with very poor sanitary conditions. It puts them at risk themselves. There is high mortality rates, so that is off-putting to them. There is morbidity rates. I'm not a medical person, by the way, so these terms are exciting to me to say. So this doesn't inspire a doctor to thrive, so we need to look at improving these conditions for doctors and provide them practical experiences as well, which is we've identified as missing. We've got Hind here, who's just come from Sudan, and she was working there, so it's quite insightful to understand what the shortfalls are. We've then looked at governance, so hospital management systems, procedures and policies that we need to implement, reporting, analytics. So a hospital is a business, although a lot of people don't consider that. So how do you run a viable business, that hospital? Because a hospital needs to make money in order for their facilities to be updated, maintained, doctors employed. There has to be health, human resource processes in place. How do you attract very high quality professionals to your hospital and retain them? So we need to look at that aspect of how to manage a hospital, and you need to bring that expertise. Procedures, policies, systems, document management systems, archiving system, all the standard stuff you get with running a business. And finally, we think that you cannot simply implement or overhaul your workforce sort of theme without engaging with the government. So we need to implement a top-down and bottom-up approach. So we're working from the bottom up, telling the government what it is we need. So we need to be able to impact government policies. And we agree with the table, I think, what was the table? Safeguarding. So the government, we need to impact government processes, procedures, policies, laws, regulations, standards to enable us to then operate and be a happy workforce, I suppose. Thank you. Very briefly.
Oh, thank you.
Thank you very much. And I believe another point here.
We also spoke about how hospitals don't only run on doctors, so we have to pay attention to training of nurses, pharmacists, physiotherapists, other allied healthcare professionals, and that there's a bigger shortage in these fields than in terms of numbers of doctors and their training. And so extra care has to be taken
in these parts of the healthcare system as well.
Absolutely, that can't be overemphasized. Thank you very much for all working on this. What we'll do is we will collate all the information, what's been written, what's been recorded as well, and it will go into the report that we'll send over to all of you to have a look at as well, before we submit it through the Department of International Development. I'll give a couple of comments, and then Sarah would like to just summarize the brief. I'm just aware about the timing. So a couple of comments.
So I think what happened is a very good start of work. يعني في a lot to do يعني. فنحن عشان نكون practical يعني I suggest لل SDU إنه يعني these things to be put in يعني when we talk about the policies يعني we take the initiative of writing the policies and we can do that. My suggestion for the SDU is to have a group of specialists in different aspects and to ask them to start writing these things or put it in writing, because I think we have a responsibility and we need to do a lot more, and we need to continue الwork, not just meeting. We have to do it and put it as a reality to be implemented. كمان لو ساعدنا في implementation.
Thank you very much. Marwa, you wanted the point, Manal, you wanted the point, like briefly.
Yeah, just to add to the workforce, I think we all forget about the ambulance services. I think that's a quite sort of important point that we need to add on and improve our ambulance services in Sudan.
Thank you, Marwa.
شكرا لكم جميعا. Indeed, just 2 points very quickly. The first one is we mentioned a couple of times grassroots, we mentioned bottom-up approach, but within that, and I noticed we were coming up with plans, they're more hierarchical system. And I think we need to be very aware of that. That might cripple us more than enable us to achieve what we want. We need to think about and see where the word has come, and then we can, instead of redoing the wrongs, then try to start from where others finish. العالم كله, they're now thinking about getting out the hierarchies from the system, giving more power to the people on the ground, اللي هي الشغل بتاع co-production ده. I think it would be very important for us to think, it's more about, when we say grassroots, we mean it. It's a grassroots approach. People are empowered. Sudan is very diverse. Every area, they've got their own needs, so it needs to come from bottom down rather than a governance يعني structure كده. ده واحد, a few hierarchical system. الحاجة الثانية عايزة أقولها, it's very important as much as إنه نحن we are Sudanese, our hearts are there. I would say a lot of us lived here for quite a long time, and our minds and mentality have departed. And as much as we feel the responsibility that we need to do something back there, somehow it can be same as a foreigner comes and say, Khawaja come and say that they want to implement. Yes, our experience here is very valuable, but we need to be very careful when we go and impose our ideas اللي هي استلمناها من هنا. We need to be supportive مع people on the ground, and we work with them together rather than thinking about influencing and imposing our views. فشكرا.
Well said, Marwa. Thank you very much. I'd just like to say a comment before Sarah concludes this session. The good thing that we've done before is work حق سياسة البديلة alternative health policy work has actually progressed, which is excellent, and now this is the second phase. So this is an ongoing project, and I would say it's not just started with the revolution, it's been going on for a long time. Sudan Doctors Union UK have been working on alternative health policies for quite a few, I'd say a couple of decades already, if not 3 decades, throughout the whole time of the Inqaz. So we're hoping for all the thoughts, all your contributions to culminate into a report that will be quite helpful and quite practical for implementation. Lots of ideas, lots of thoughts, thank you very much. Quite a lot of inspiring comments made by many. And again, I have to say, I'm always inspired by the youth. That video we saw was excellent, a lead to this session. So thank you very much. Sarah, if you'd like to conclude.
Yeah, thank you. I will start from where Marwa stopped, which about definitely we have to work with Sudan about what is their plan and strategy. And I think we were ahead because we have been working with المكتب الموحد, التنسيقية الكوادر الصحية, but recently during the visit, several of us visited Sudan, and I think all of us have tried to understand what's happening. But in a formal meeting, Dr. Huda was there as well with Akram Aitom. We have asked clearly, what are you expecting from us? What can we do? Because we may be picking the wrong project, and can we just have an insight about the plan for the next 3 years so we can see where we fit. But the other things that we have realized, and we should not underestimate that, the NHS England is an important organization. It's one of the best health organizations in the world, whether we think that or not. And therefore there is quite a few policies and strategies already there. And one of them that we have used was the safeguarding. So the comment about safeguarding, we looked at the safeguarding policy for NHS England, and we have started to modify that so that it can fit Sudan. So we have a lot of things that we can utilize if we have been asked. That's the first thing. I quite agree about إدارة المختبرات or quality control and licensing, so that's an idea that we will take, and about the screening program. The trauma center, we are very honored that some members have provided a project proposal for a spinal and head and injury trauma center, and that's something that has been in the pipeline. Mental health is now part of the DFID after we discussed with them about the nation trauma. After what happened during the revolution, apart from the clinical mental health, that there is a need for, as a nation, outside Sudan and inside Sudan, people need help and support, and they are considering that. They thought that they were not thinking about it before. Conflict zone, we have agreed that, it has, we would like DFID and the partners, who are the UN usually, and WHO and UNICEF, to be allowed into the conflict zones area, because until recently they are not they were not having any access. Primary care, just to give you an insight, the European Union is providing a small fund for primary care in Sudan, and I think that will link with our objectives. But I think we have to concentrate on the allied health professionals and training them. So we will appreciate if people have got any sort of project or are interested in that area, because it's something that people want to work on. Governance, I think we will agree. We'll take all of the comments. It's very structured. Workforce. What we have mentioned to DFID and to Akram, that we have a program. I don't think anybody here has not been an educational supervisor or clinical supervisor, or have been a college tutor, or not been linked with the royal colleges, and therefore we want to utilize that so that we can help with improving the quality of training. And if we improve the quality of training, trainees will be more satisfied about the work in Sudan, because this is what we can deliver, because we don't have money or resources to change things overnight. But trying to improve the quality of the training, that's something we can do. Thank you.
Thank you very much. That brings an end to this session. There's one small message to the students from the Commissary. I'll pass on before we proceed to our awards ceremony session.
Just before we round it all up, I think we should do one final applause for all those brilliant students from Sudan. Yeah. Thank you for the quality scheme. we're definitely going to expand on it. And these guys are setting up a very positive and a very nice image in Cambridge now. I mean, I think we already started to hear a lot of positive feedbacks. And this may lead me to leave you with a suggestion. I mean, in this country, when you are a medical student, at that moment you are eligible to be a member of the BMA. Why are we not doing that? I mean, from the SDU point of view. I'm going to leave that with you, Sarah.
They can be members of probably SDU and النقابة الشرعية في السودان. It depends where you're at. While they're here, we're always happy to have them as affiliates during this time. Yeah, affiliated, surely. Lovely suggestion. Thank you very much, Mr. Misari.